हाँ आगे करो नहीं ये थोड़ी है लेक्चर लगाओ लेक्चर मैडम का लगाओ मेरा लगा दो फर्स्ट बेसिक साइंसेस जो सीनियर है वो मेंटेन करते हैं मैडम को पूछ मेरा तो लगा दे दिया है सबरा ने अस्सलाम वालेकुम and a very good afternoon to all of you. We now welcome our foreign faculty for the first lecture of this session, that is classification and description of the pelvic floor disorders. Welcome, ma'am.
Good afternoon and assalamu alaikum everyone. Very sorry to be late. So today we are talking about, yesterday we were talking about basic sciences, about anatomy, embryology and neurophysiology and pharmacology. As you know, that in urogynecology, in, nomenclature and classification is really important. The reason for that is because of research purposes, because we can talk about various things thinking it is the same thing, or sometimes we are talking about the same thing but people think it is a different thing. That's why there is a Urogynecology as well as International Urogynaecology Association, and that particular committee's purpose is just to make definitions and classifications. So everything is very, very standardized. And because of that, when we say urgency, there is a definition for that so that we know what we are talking about. So this topic is particularly about nomenclature and definition, so it may seem boring, but there is a big purpose of it so that when we do research, we know what we are talking about. So, as I said, there is a committee particularly, there are like 16, 17 members from all over the UK as well as America, and their purpose is to sit down 3 times a year and to polish these definition and classification. And this is called Joint Report on Terminology for Female Pelvic Floor Dysfunction, and it is part of IUGA as well as International Continence Societies. So there are 250 separate definitions. Don't worry, we are not going to go through all of them, that's a lot. But we will talk about the common ones which are applicable in everyday urogynecology. So aim is significant aid to clinical practice as well as stimulus for research. So the current nomenclature was agreed and published in 2009, but it is revised every year, and if there are any changes, then they are notified. So first of all, we will talk about terminology which involves bladder for urinary incontinence symptoms. So main symptoms we are talking about is urinary incontinence, and let's see what's the definition for that. Involuntary loss of urine. So if you see, it is very, very simple. And simple things are good because we can remember them and we can relate to them rather than talking too much. So just four words: involuntary loss of urine is urinary incontinence. And then what is stress urinary incontinence? We all know what it is, but the way they define it, and they would like everyone to define stress incontinence as involuntary loss of urine on effort or physical exertion, for example, sporting activities, or on sneezing and coughing. A lot of people, they don't understand the difference between stress incontinence as well as overactive bladder. And sometimes in general practice, people use these terms interchangeably. These two conditions are entirely different from each other. So we must know that stress incontinence is something which happens on stress, and it's not mental stress, it's physical stress. Any condition which will increase the intra-abdominal pressure, for example, coughing, sneezing, jumping, laughing, running, and with that activity when there is leaking of urine, that is stress incontinence. Now the next one is urgency urinary incontinence. And what is urgency? When we have to rush to the toilet, okay? If somebody needs to go, they need to rush. Otherwise, there will be loss of urine. So let's see what's the definition for that. Involuntary loss of urine associated with urgency. So what is the definition of urgency? For example, if one of you now needs to go to the toilet, they won't wait for me to finish this lecture. They must go now, otherwise they would have accident. So this is that type of urgency. They are not able to hold it more than few minutes. Okay? So that's what we need to remember. The actual urgency of urine is quite a debilitating problem. And then the next definition we are talking about is postural urinary incontinence. So if you notice, before every definition, the first 4 words they have kept the same, which is for the urinary incontinence, which is involuntary loss of urine. So if you, for all the students, if you remember these 4 words, then rest of the definitions, they start with these four words. So it's easier to memorize when you are going for exam or something. So involuntary loss of urine. Oh. Thank you. ठीक. So involuntary loss of urine associated with changes of body position, for example, rising from sitting or lying position. Okay, so that is postural incontinence. So what do you think, what would be the more etiology of postural incontinence? Will it be overactive bladder or will it be stress incontinence, if we have to point to one side? Yeah, so it could be anything, that's why they have not defined it. If somebody has overactive bladder, sometimes there is cough-induced overactivity and sometimes it is stress incontinence related to change in posture. So we move on to more symptoms. So nocturnal enuresis, which in simple words is called bedwetting. Okay, so like babies, as they do bedwetting in the childhood. So unfortunately, adults can also have this problem, and this is extremely troublesome problem. If somebody is asleep and then they wake up and they realize they have wet their bed, how embarrassing is that? That can break relationships, that can have huge impact on family finances because they have to wash all the clothing, all the mattresses get spoiled. So it's extremely distressing problem, which is nocturnal enuresis. So let's see what's the definition. Involuntary urine loss which occurs during sleep. So in simple words, it is bedwetting, but people think that bedwetting is related only to babies, but it can happen to adults as well. And let's see what's the mixed urinary incontinence. Involuntary loss of urine associated with urgency and also with efforts or physical exertion or sneezing or coughing. So in mixed one, they have joined the both definition of urgency incontinence and stress incontinence. And most of the women who have urinary incontinence, almost 80-90% of them will have mixed picture. So that is the commonest type of incontinence where we cannot pinpoint is it stress incontinence or overactive bladder because they have both type of picture. So this is the commonest picture which we deal in everyday clinical practice. So this is the one you will listen to patients and you will say yes, she has mixed urinary incontinence. The next one is continuous urinary incontinence. Again, they have kept definition, so it's so beautiful, they have kept it so simple and easy for everyone to remember. It is continuous involuntary loss of urine. So what could be the reasons for that, for continuous involuntary loss of urine? Any ideas why somebody will keep leaking continuously? And I'll give you a hint, think about Africa. Exactly, well done. So any fistulae, which are a hole in the bladder, which is leaking through vagina. So they have no control. It is not related to coughing, sneezing or urgency. There is a hole. As soon as urine comes in the bladder from kidneys, it will come out, so which is continuous loss of urine. So if you see, these things are so simple, but they are so much relevant to clinical practice. And sometime in urogynecology, you don't need any fancy testing, and just being aware about these definitions, being aware about etiology, you can diagnose the patient sitting there and then. And now next one is insensible urinary incontinence. So when somebody coughs or sneezes, they have leaking, so they are aware, oh my God, so there is some dampness, I have just sneezed and there is some leaking. Somebody needs to go to the toilet, they rush to the toilet, while getting to the toilet they leak, so they know it's urgency. But unfortunately, sometimes you have nothing of that, you don't need to go to the toilet, you are not coughing and sneezing, you don't even realize that actually your underpants or your clothing is wet. So that is called insensible, without you realizing that there is any problem, and you don't realize, and actually you have become incontinent. Usually insensible loss of urine is small volume, it's not large volume. We'll talk about volumes when we talk about other things. So the main thing is woman is not aware how it occurred, it just happened. Coital incontinence, this is unfortunately one of those things people don't talk about, and this is something which is extremely embarrassing for people. In the UK, women are a bit more aware about these problems, so they don't feel shy. But in India, I don't think anyone would ever tell you they could have this problem, but you need to ask direct questions. Involuntary loss of urine with coitus. This symptom might be further divided, that is occurring with penetration or occurring at orgasm, because the etiology is different for both of them. If you need to ask, as soon as you start, does it happen or does it happen at the end? So if it happens at the start with penetration, usually it is stress incontinence related. This means there is problem with the pelvic floor muscle. But if it happens at the end of the coitus, at orgasm, usually it is because of overactive bladder. So if we know these little things and we further classify, ask her confidentially, then we can find out the cause of the reason. But mostly they would say it is mixed picture as well. So we need to keep that in mind. So we were speaking about symptoms, which was all the symptoms in urogynecology. Now we are talking about lower urinary tract symptoms. So before we were talking about patient's history, now we are dividing our things into storage, voiding and post-micturition phase. As yesterday we were discussing, the main thing is storage phase and voiding phase, but we did not mention post-micturition phase. So we will divide these symptoms into three, and now let's see. So storage symptoms. So what is storage? That we are supposed to fill the bladder, keep filling it, and only go to the toilet when we really need it. So increased daytime urinary frequency. So what do you think, an adult female, how many times would it be normal for an adult female to go to the toilet in the daytime? What we would classify as normal? Any ideas? Yeah, that's good. Any other ideas? Any other guesses? So if you think about it, when we all wake up, first thing we do, most of us, we go to the toilet. Then we have breakfast, and when we are getting ready for work, maybe before we come out of the house, we go to the toilet. So that is twice. Then we have, before lunch, when we have a drink or something, we go to the toilet. That is third time. Then we have lunch. When we pray Dhuhr, maybe we go to the toilet 4 times. Then maybe 1 time with Asr, then Maghrib, 5, and then Isha, 6. For us it is easy because we divide our routine with the prayers time. But it is surprising that other people who are not practicing Muslim, and you talk to them, and actually their normal bladder pattern is also similar. So our prayer times are quite physiological. So 5 to 6 times in the daytime is a normal frequency to go to the toilet, and night time going once is normal. So if somebody goes once, that's perfectly normal. And more than one we classify as nocturia. So let's see what the definition tells us. Micturition occurs more frequently during waking hours than previously deemed normal by the woman. So, quite intelligently, they have not mentioned the number of times somebody needs to go to the toilet to classify as increased frequency. The reason is that people are different. And why people are different? Because of our intake of water. There are certain people who would not drink more than 1 glass of water in a day. Yeah? And some people, they drink 3 liters of water. So, whatever we drink, it needs to come out. So that's why if a woman's frequency all her life has been 5 times in a day and now it has become 15 times in a day, so which is abnormal. But if somebody from the beginning was going maybe 10 times in a day and now they are going 15 times, it has changed from the previous. So what they have cleverly mentioned, they have not mentioned the frequency here, but they are relating it to the past frequency, and now if there is a change, significant change in frequency, that's what the definition says. Interruption of sleep, we are talking about nocturia now. Interruption of sleep 1 or more times because of the need to micturate, and each void is preceded and followed by sleep. For example, if somebody says, oh, last night I went to the toilet 5 times, and you would say, oh, actually that's abnormal. But when you ask them, what were you doing last night? They say, we were in a party and we were having drinks. And if then they went to the toilet 5 times, that's perfectly normal because that's like a daytime. But if somebody said, oh, I went to bed 9 p.m. and then I woke up every 2 hours to go to the go to the toilet, because I couldn't sleep, I woke up because of the sensation of urgency. I had to go to the toilet, and when I came back, I was so sleepy I have to go back to sleep. Because sometimes people are waking up for some other reason and they keep eating and drinking and then they go to the toilet. That is not nocturia. Nocturia is the sleep pattern is disturbed because bladder has woken them up. It's really important to clarify this point because pathology of the nocturia can be quite complex. So what is sensation of urgency? Sudden compelling desire to pass urine which is difficult to defer. So the word we use in the UK is dash to the toilet. This means it cannot be delayed. Whatever happens, I just must go to the toilet. I cannot wait. Okay? And this is such a debilitating thing that you do not see what's happening around you. The overactive bladder is very, very debilitating. You just must go. And that is a sensation of urgency. So overactive bladder or syndrome. So what is a syndrome? So they have combined the top things and then they have made the definition. Urinary urgency, usually accompanied by frequency and nocturia, with or without urgency urinary incontinence. 70 times is too much. You can't do anything else apart from going to the toilet. So this happens. So as soon as she passes urine, she comes out and she goes again. Post-micturition leakage, further involuntary passage of urine following completion of micturition. So post-micturition leakage, the another term for it is post-void dribble. You go to the toilet, you have cleaned yourself, you have dried yourself, you have stood up, and some urine comes out. This is called post-void dribble or post-micturition leakage. There is etiology. Can anyone think of that? Why could that happen? You have just finished passing urine, you have stood up, some urine has come out. Maybe some of us has experienced that when we stand up. So what could be the reason for that? So the interesting thing is that with each of these etiology, there is a host of diseases related to it. And awareness is the one which are going to get there. Because what happens when patients come to us with urgency, we give them medication, we do some sort of surgery, and we hope they get better, but they don't get better. The reason is we have not been digging enough to find out, and that is why this lecture is the most important lecture, because then from this you can understand it's not as simple as it seems. There are numerous pathologies which can cause numerous symptoms, and exactly same way there are numerous treatments as well. But first of all, we need to define it and find out. So post-micturition leakage, if nothing comes to your mind, just think about diverticulum. Yeah? It's a pouch of the urethra. So when we pass urine, some urine stores there. Yeah? So we think we are done, we stand up and it leaks. Yeah? So that is one example of post-micturition or post-void dribble. So how beautiful is it that with knowledge we can understand so much. We have not even touched our patient. Just talking to her, we can understand. We don't need machines, we don't need anything expensive. But just the intellect, talking to patient, we can understand what's wrong. Another thing which can come to your mind, which is post-void dribble, could be a fistula again. Yeah, so urine has collected there. It's a small fistula, which is crisscross fistula, so that when she passes urine, because of sitting down, some urine leaks in the posterior fornix of the vagina. So when she stands up, that urine comes out. When it is post-void dribble. Yeah, sometimes it is a prolapse as well. Because what happens with a large rectocele, when she is passing urine, and with large genital hiatus, some of the urine is going behind the rectocele and is going in the posterior pouch. When she stands up, it could be pouch of Douglas urine coming out. So all these things, it's just thought-provoking definitions. So position-dependent micturition. Having to take specific positions to be able to micturate spontaneously or to improve bladder emptying, leaning forward or backwards on the toilet seat or voiding in semi-standing position. So what this means, the normal toilet, for example, if we have an Indian toilet where we squat on the floor, or if we have a sitting toilet, if a woman used to pass urine on that comfortably, but now something has changed. She cannot pass urine, and now she has to do various things in order to pass urine. So what has changed? So this means there is some anatomical change. Yeah, so in this one, when there is position related, some anatomical change has happened. So what that could be? Maybe a Birch-Colpo suspension. Interesting, isn't it? Because what we have done, so in Birch-Colpo suspension, 3 sutures, these are 3 stitches on the side. We have lifted the vagina up with the help of permanent plastic stitches, which has splinted the urethra in a way that it cannot operate in the normal way because anatomy has changed. So woman has to bend forward, backwards, rock side to side. So this could be one of the indication of this type of problem. So we have a patient who only passes urine when she's bending her knees in standing position. So she has to go to her shower and pass urine. How embarrassing is that and how difficult is that? Because in normal public toilet she can't go. So she has become disabled. She can't pass urine. There is a solution for that. We'll talk about solutions in the further lectures. Okay, so now we are talking about dysuria. Very troubling, isn't it? Passing urine shouldn't be a chore, shouldn't be a trouble. Complaint of burning or other discomfort during micturition. Discomfort may be intrinsic to the lower urinary tract or external, which is vulvar dysuria. So what it says that sometimes the sensation of pain is actually inside the bladder. You have actual pain inside your bladder when you are passing urine, or most commonly you have sensation of pain in your urethra. Yeah, so that is the intrinsic, but sometimes it is outside. The actual coming the urine out of urethra is not painful, but when it touches the vulva it hurts. So it is local sensation of burning outside, which is extrinsic, or inside. So any examples of intrinsic pain or dysfunction? Is very commonly, it's the commonest thing, isn't it? UTI, exactly. Urethritis, sexually transmitted infection which cause chronic urethritis. So it is intrinsic pain. Extrinsic, as we already discussed, if it is atrophy, vulvovaginal atrophy, lichen sclerosis, which causes itching and soreness on the vulva, or lichen planus, or other skin conditions, or any other local skin condition. So when urine touches there, it burns. Next one is retention. Complaint of inability to pass urine despite persistent effort. Very painful condition that you know your bladder is full, you are trying your hard, nothing is coming out. So that is called urinary retention. Any guesses? What volume do we say, oh, this is retention now, or retention can be irrespective of volume? What do you think? Mm-hmm. Yeah, so I think it is the sensation based. Sometime even if there is 300 mils of urine in the bladder, but if somebody can't pass it, it is quite painful. And sometimes there is 1 liter because of actual problem. So any retention means bladder sensation of full bladder, but you are not able to pass urine. But when somebody mentioned 150 mils, that is post-void residual. We use that terminology somewhere else. When we discuss incomplete emptying of the bladder, then we let them pass urine and then we do a scan, and if it is more than 150 mils, or if they have passed 1/3 and they have kept 2/3. So there is a rule of thirds. So that is also post-void residual. For example, if somebody has 300 in their bladder, they have passed 200, kept 100, that's normal, not a problem. But if they have passed 200, if they have passed 100 and kept 200, that's a problem. Okay, so now we are going to pelvic organ prolapse symptoms, isn't it? Before we were talking about voiding phase, storage phase, urine sensation phase, sensation related symptoms. Now we are coming to pelvic organ prolapse. And again, this is a can of worms, because prolapse is very ambiguous term, and this is so important to standardize this. And this is a good starting point, because only because of these definitions we can do research, we can relate to each other, and we can help patients. So that's why this is vital to know these things. So the first we are talking about is vaginal bulging. So complaint of a bulge or something coming down towards or through the vaginal introitus. So here in India, people will say, "Mujhe boj padta hai," yeah, some pressure is felt, something like that. But in English, it is just a bulge or something coming down and not feeling comfortable. The woman may state she can either feel the bulge by direct palpation or see it aided with a mirror. So that is the main thing. Pelvic pressure, complaint of increased heaviness or dragging in the suprapubic area or in the pelvis. So you are aware about something down there. Some people will say, oh, there is like a sensation of golf ball, or there is sensation of an egg there, or there is some sensation of soft flesh. So these are the various terms a woman can use. And she will say, oh, I had a look and I can see it, or she will say, I have seen with the mirror and there is a bulge there. Pelvic pressure, complaint of increased heaviness or dragging in the suprapubic area or in pelvis. This is an associated symptom of prolapse. Bleeding, discharge, infection. Complaint of vaginal bleeding, discharge, or infection related to dependent ulceration of prolapse. This is really important, because if somebody has prosidentia, which is complete prolapse of the uterus, so the cervix keeps rubbing on the knickers or around the thighs, it can cause ulceration, it can bleed, can cause infection. Very, very difficult to control if there is no facility to operate or do anything about the patient. We'll talk about it, how to solve it later on. Okay, so we continue to do pelvic organ prolapse symptoms. The next one is splinting or digitation. This is a terrible, terrible thing which people feel very embarrassed to discuss. But we all need to address this. What is splinting or digitation? This is related to rectocele or any large prolapse, because angle of the rectum has changed now, so they are not able to empty their rectum easily, and they have to aid themselves by putting their fingers in the vagina, pressing on the bulge. It's a very common symptom, so people don't mention it. Yeah, so this is called splinting. So if we have a name for it, we will remember, and we will try asking patient, when you go to the toilet, is it easy to empty your rectum in one go, or you try to go, nothing is happening, poo does not come out, and you have to put your fingers in the vagina or on the side to press on the bulge in order for the poo to come out. So this symptom has been given name of splinting or digitation. Sometimes patients have to do manual evacuation of stool from their rectum, and that is where digitation is related to, but splinting means pushing. Let's see what the definition is. Need to digitally replace the prolapse or to otherwise apply manual pressure to the vagina or perineum or to vagina or rectum to assist voiding or defecation. So splinting and digitation can also be to empty the bladder, because if there is complete kinking of the urethra, which can happen with prosidentia, they cannot pass urine. So they have to push the prolapse back or push on the cystocele to empty the bladder. Low backache. Low sacral or period-like backache associated temporarily with pelvic organ prolapse. So, although prolapse itself is not a painful condition, it does not cause pain, but because of constant dragging of uterosacral ligaments, which are attached to the back, so low backache can be associated with prolapse. So, what is the actual prolapse? The descent of one or more of anterior vaginal wall, apical segment of the vagina, which could be uterus, cervix, or post-hysterectomy, or posterior vaginal wall. Absence of prolapse is defined as stage 0 support. Stage 0 means normal. We are not talking about stage 0 of POPQ or 0.0 of POPQ. That is very different. We are talking about stages of normal anatomy. So 0 means normal anatomy when we are classifying prolapse. Prolapse can be staged from stage 1 to stage 4. So, because this is not about the classification of prolapse, it is only symptoms. So now we move on to sexual dysfunction. Dyspareunia, persistent or recurrent pain or discomfort associated with attempted or complete vaginal penetration. So painful sexual intercourse, this is the definition. Superficial dyspareunia, pain or discomfort on vaginal entry or at vaginal introitus. Yesterday we were discussing about hymen problems, imperforate hymen, very small hymen, or a ring-like hymen. So superficial dyspareunia can be because of that. Recently I saw an Indian girl, she's an engineer, such a bright girl, very, very bright, in excellent job in Birmingham. And she came to me and she said she got married 7 years ago, and since 7 years she has not been able to achieve sexual intercourse. And it was so heartbreaking to see, because I saw and she had imperforate hymen. And I got shocked that she's an engineer, she's so educated. Why did she not look it up? She said, I thought maybe I'm just abnormal or maybe something wrong. And her husband was a very sweet person as well, and he didn't want to cause her any pain. It took 5 minutes to sort that out. 7 years of pain. With the knowledge, you can help them so much. It took 5 minutes to just excise her hymen, and she was so relieved. So meaning to say, these are small things. With knowledge, we can help so many people. It's like sadka jariya, isn't it? We relieve someone's pain. Whenever they have good symptom control, they pray for us. So that is superficial dyspareunia, and I mentioned just one cause, which could be a hymen problem, but there are many other problems. Estrogen deficiency is one of them. Deep dyspareunia, pain or discomfort on deeper penetration, mid or upper vagina. So deep dyspareunia is a bit complex, because if you think about superficial dyspareunia, it is something wrong with the size of the introitus or maybe estrogen deficiency. But upper vagina is very roomy. It is not narrow unless there is a septum or some problem. But if vagina is normal, particularly if they have a normal childbirth, the deep dyspareunia is mostly related problems in the pelvis. So what could be the reason of deep dyspareunia? Anything comes to the mind? Exactly. So there are multiple reasons. One is pelvic inflammatory disease and endometriosis. These are the two common ones. Or maybe a UTI sometime, ongoing chronic UTI can cause bladder pain and dyspareunia. Obstructed intercourse. Vaginal penetration is not possible due to obstruction because of, as we discussed yesterday, congenital anomalies, septum or various types of problems, or very, very tight suturing after forceps delivery. When everything is edematous, you suture it so tight, it looks at that time good, but later on it can cause problem. Vaginal laxity, complaint of excessive vaginal laxity. Some people say, oh, after childbirth it has become too loose, I don't have any sensation with sexual intercourse, or actually I feel as if I'm passing wind through vagina because it is so roomy and introitus is so big. So wind gets trapped there, and when they stand up, they feel as if they are passing wind through vagina. Can be very embarrassing because they have no control of it. So now we are talking about, we are nearly there, I know it's too long, symptoms of anorectal dysfunction, because in urogynecology we are talking about all three compartments. So anal incontinence, involuntary loss of feces or flatus, fecal incontinence, involuntary loss of feces, which can be solid or liquid, passive fecal incontinence, soiling without sensation or warning or difficulty wiping clean. They have passed their motion, and after that they keep cleaning themselves and still there is more. So they think they can't even clean them enough. Coital fecal incontinence occurs during vaginal intercourse. Flatal incontinence, this can be very embarrassing for people because of social reason, involuntary loss of flatus, but there is something which can be done. So fecal or rectal urgency, sudden compelling desire to defecate that is difficult to defer. Again, it is very socially very embarrassing. Fecal flatus urgency incontinence, involuntary loss of feces or flatus associated with urgency, straining to defecate, need to make an intense effort by abdominal straining or Valsalva to either initiate, maintain, or improve defecation. So this is sort of like obstructive defecation. This is another can of worms. Feeling of incomplete bowel evacuation. The rectum does not feel empty after defecation. This is a typical symptom of a rectocele or rectorectal intussusception. Okay. Symptoms of anorectal dysfunction continues. Diminished rectal sensation. So diminished or absent sensation in the rectum that poo is there and they need to go to the toilet. Constipation. Bowel movements are infrequent and or incomplete, and or there is a need for frequent straining or manual assistance to defecate. So there is some criteria we can talk about later. Rectal prolapse, external protrusion of the rectum. So we can see it. Okay, we move on to lower urinary tract pain and or pelvic pain. So bladder pain. So this is what I was talking about, bladder pain syndrome. So what is bladder pain? Suprapubic or retropubic pain, pressure or discomfort related to the bladder, and usually increasing with the bladder filling. It may persist or be relieved after voiding. Urethral pain, pain felt in the urethra, and woman indicates the urethra is the site of the pain. Vulval pain, pain felt in and around the vulva. Vaginal pain, pain felt internally within the vagina or above the introitus. Perineal pain, pain felt between the posterior fourchette, posterior lip of the introitus and anus. Pelvic pain, pain perceived to arise in the pelvis, not associated with symptoms suggestive of lower urinary tract, sexual, bowel or gynecological dysfunction. It is less well defined than the above types of localized pain. Pelvic pain, have anyone heard the word central sensitization syndrome? No? So it's a very complex entity because in UK there is a separate department which is the pain department. They deal with pain. Doesn't matter from where the pain is coming from. So their job is just to deal with the pain, chronic pain. So there is an entity which is called central sensitization syndrome, but because of various reasons, somebody had pain. For example, somebody had kidney stone, they have like ureteric stone, they had a lot of pain. So that episode is over, they got rid of the stone. But the nerves in the pelvis got sensitized to the pain that they got so stimulated that even after the pathology is gone, pain remains there. So this is called central sensitization syndrome. And now there is a lot of work being done knowing that actually the actual event was gone, but because of sensitization of the pain system, this pain is not going away. So there is a pain modulator group. You might have heard gabapentin and that type of group, which we can use to deal with this type of pain. Or there are certain injections which we can give. Cyclical menstrual pain. Cyclical pain related to menses that raises the possibility of a gynecological cause. This is obviously a common thing we deal with. And then pudendal neuralgia, that is a disturbing one. Burning vaginal or vulval pain anywhere between anus and clitoris, and pain associated with tenderness over the course of pudendal nerve. It's quite disturbing and very difficult to treat. Urinary tract infection, how do we define? Scientific diagnosis of a UTI is the finding of microbiological evidence of significant bacteriuria and pyuria, usually accompanied by symptoms such as increased bladder sensation, urgency, frequency, dysuria, urgency urinary incontinence, and or pain in lower urinary tract. So we actually sometimes we overdiagnose urinary tract infection. There is actually no infection. So there are two parts to diagnosis. One is patient's symptoms, that she has pain on passing urine, there is pain in the bladder, there is temperature, there is lower abdominal pain. And second part is lab diagnosis, which is the first part is dipstick. So dipstick we'll talk about. Then we need two things to diagnose on the dipstick, not only one thing. So one is very high number of white blood cells or pus cells. And the second thing which must be present is presence of nitrites. Okay, so you must remember, if nitrites are positive, that is highly indicative that this urine sample needs to go to lab for culture. So we always focus on nitrites along with white cells and with symptoms. Recurrent urinary tract infection, at least 3 symptomatic and medically diagnosed UTI in the previous 12 months. So recurrent, the definition is 3 episodes in 12 months. The previous UTI should have resolved prior to further UTI being diagnosed. Otherwise, it will come in chronic UTI. Okay. Other related history like hematuria or catheterization will assist in diagnosis. Okay, then that was all the symptoms, related definitions. Any questions? So many problems. So before this lecture, you would think the urogynecology is quite simple and straightforward. So that's why there is a full committee. Can you believe, like 16, 17 consultants, they sit together and they define these things to make very, very simple definitions so everybody can understand, even with no knowledge of urogynecology. But this is a good starting point, because now you would be aware, maybe you keep this little guide in front of you, taking urogyne history, and see like which part can help patient, because so many of these things, if you know the background, you can diagnose just talking to patients. Thank you very much. Thank you.
Thank you so much, Afshan ma'am, for lucidly explaining the complex concepts. Moving ahead, I would now like to invite our next speaker, Dr. Shazia ma'am, for her talk.
It's nothing new now. Ma'am has already covered the physical examination in history almost. But it will be a reinforcement to the previous lecture. So at the end of the session, the learners will be able to take a elaborate history and do a and perform a physical examination in order to reach a diagnosis. Now, again, the reinforcement of the various problems. The incontinence is an involuntary leakage of the urine. Then stress incontinence, involuntary leakage of the urine with an effort. Urgency is involuntary loss with urgency. Mixed incontinence, it is a mixture of urgency plus SUI. Continuous urinary incontinence is the continuous dribbling of the urine. Then frequency is number of voids per day from the waking up in the morning till she sleeps at night. Increased daytime urinary frequency is increased micturition during waking hours of more than 7 per day. Nocturia is interruption of the sleep 1 or more times because of the need to micturate, and overactive bladder syndrome is urinary urgency along with frequency and nocturia with or without urge urinary incontinence in the absence of UTI and other pathology. Now coming to the history taking, the duration of the time with urine loss, associated symptoms and the severity should be asked from the patient. Urine loss with activities like coughing, jumping, sneezing means it indicates the stress incontinence. Symptoms preceded by an urgency episode indicate an urgency incontinence. Then we should always take the history of UTI, previous surgical history. Some surgeries lead to SUI and some surgery lead to incontinence, urge incontinence. Then age of the patient is very important because the stress urinary incontinence usually occurs in the later decades of the life, that is the fifth decade. Older age group have the mixed type of symptoms. Then after vaginal delivery, it is usually a stress urinary incontinence. Pregnancy also disposed to the stress urinary incontinence. Then high parity, it should be taken into account because it also leads to the stress urinary incontinence. Similarly, obesity, because obesity leads to the levator aniaprophy and which predisposes to the new onset of stress urinary incontinence. Then a disease which diabetes which causes diuresis and neurovascular injury, and it leads to the detrusor overactivity. Similarly, the history of cough should be asked, history of smoking. Then functional causes for incontinence, maybe there is a mnemonic, that is diapers. Then UTI. Diapers is delirium, infection, atrophic urethritis, vaginitis, pharmacological causes, psychological causes, excessive urine production, restricted mobility, and stool impaction. Then the drugs, like we should take always the history of the drug intake, benzodiazepine, that leads to the diuresis, alcohol, similarly diuresis, anticholinergic, alpha agonists, beta blockers, calcium channel blockers, and ACE inhibitors. Then coming to the physical examination. So we should always do a general physical examination. The mental and cognitive functions of the lady should be assessed because it may lead to the urgency, frequency, and anuresis. Then the neurological functions should be assessed, and history regarding the Parkinson's, multiple sclerosis should be taken, which leads to urge incontinence. Then the cardiovascular system should be taken into account because, as madam has said yesterday, it leads to the nocturnal micturition, nocturia, because of the fluid going to the bladder at night. Then pulmonary functions should be assessed. COPD especially leads to the stress urinary incontinence. Then again, the nutritional status of the lady, obesity, mobility, and the gait should be assessed. Then coming to the pelvic examination, the goal is to investigate pelvic support defects. Then examination should be done in the lithotomy position. It can be done in upright or the standing position also. Evaluation of the vulva, vagina for the atrophy, vaginitis, and dermatosis should be done. Inspection or palpation of the urethra may reveal the tenderness or the mass in case of infection or a diverticulum, as madam has already mentioned. If there is pelvic organ prolapse, the staging should be performed. Integrity of the pelvic floors and levator ani muscles should be assessed. The method is with the 2 fingers in the vagina, the patient is asked to contract the muscles used to hold the urine or to avoid passing gas. The ability to contract and strengthen the duration of the contraction are all measured. Then bimanual rectovaginal examination should be done. Then a test which is obsolete now, that is a Q-tip test. It is done to assess the motility of the urethra. So introducing a cotton-tipped swab into the urethra and asking the patient to do a Valsalva maneuver to measure the angle of the deviation of the urethra. More than 30 degrees deviation is consistent with the hypermotility of the urethra. Minimal or no deviation suggests SUI, stress urinary incontinence. But this test is not routinely done. Cough stress test is done either with a full bladder or an empty bladder. The advantage of doing it with the full bladder is that it is easier to demonstrate the urine loss from the urethra in a woman with SUI. If the history is suggestive, patient is asked to stand up and possibly jump or cough vigorously while the examiner observes the urine. A positive empty bladder test indicates SUI and intrinsic sphincter deficiency. Then a test which is very easy, that is done by the ultrasonography, the post-void urine. And the post-void residual urine volume is amount of urine in the bladder within 10 minutes from the voiding. And if it is more than 150 ml, it is abnormal. Then simple bladder test is the bladder diary. The patient is asked to measure the day and night urine volume, look for 24 hours total urine output, number of voids per day, average voided urine, and bladder capacity. The patient also documents the time a urine loss occurs and whether associated with a stress activity like cough, sneezing, cough, or with urgency. Then last but not the least, the urine analysis to be done to rule out the UTI. Then the pad test, patient is asked to wear incontinence pads before and after taking the medication to determine if the drug results in a decrease in volume and frequency of the incontinent episodes. Pad test detects the presence of urinary incontinence that is not demonstrable even with a full bladder. Now coming to the pelvic organ prolapse. It is the progressive herniation of the pelvic organs through the urogenital diaphragm. Then pelvic supports are the common pelvic supports disorders are the rectocele, which is a posterior defect, the cystocele anterior, antrocele posterior, and the uterine prolapse. A rectocele is a protrusion of rectum into the vagina lumen resulting from the weakness in the muscle wall of the rectum and the paravaginal fibromuscular connective tissue which holds the rectum in place posteriorly. And antrocele is a herniation of the peritoneum and the small bowel and is the only true hernia among the pelvic support disorders. A cystocele is a descent of the urinary bladder with the anterior vaginal wall. These are the pictures which is showing the normal. Here is the cystocele and the rectocele. This is the complete prolapse. Then the risk factors for the prolapse are increasing age, frequent vaginal deliveries and more vaginal deliveries, then the increased parity, constipation, obesity, and chronic obstructive pulmonary disease. Other risk factors are history of hysterectomy, obesity, previous prolapse operations, and the race. Symptoms. As ma'am has already covered in detail, then there can be voiding dysfunctions, including urinary incontinence, obstructive voiding symptoms, urinary urgency, frequency, at the extreme, urinary retention, and upper renal compromise with resultant pain or anuria. Other symptoms often associated with pelvic organ prolapse include pelvic pain, defecatory problems like constipation, diarrhea, tenesmus, fecal incontinence, back and flank pain, overall pelvic discomfort, and dyspareunia. Physical examination is divided into compartments. The anterior and the posterior compartments are best examined with the Sims speculum. It is a very simple speculum. It is bivalve. The speculum is placed posteriorly to retract the posterior wall downwards when examining the anterior compartment and placed anteriorly to retract the anterior wall upwards when examining the posterior compartment. A rectovaginal examination is also done. During the evaluation of each compartment, the patient is encouraged to perform a Valsalva maneuver so that the full extent of the prolapse can be ascertained. It may be helpful to perform a standing straining examination with the bladder empty. This is for postgraduates. Now, POPQ is examination provides a standardized measurement system to allow the more accurate assessments of the post-operative outcome and to ensure uniform, reliable, and site-specific descriptions. This is a reinforcement of yesterday's lecture. Madam has simplified, but the standard thing is there are three things with the genital hiatus, that is GH. Okay? Perineal body and the total vaginal length, which will be coming.
ये सुनो ये बना रखा है रुको रुको ये बनाया था कल ये बना के रखा था इसलिए
So it is the anterior part, this is the posterior part, and these are the landmarks in the middle. That is the genital hiatus, the perineal body, and the total vaginal length. This is the anterior part, which has got 3 points, A, B, and C. Anterior will be AA, BA, and C. Okay? A, B, and C points. तो anterior के लिए हमें क्या करना है? A. A for anterior. AA and BA. फिर posterior में हमारा same है. A, B, and D points. Okay? Here it will be AP and BP. Okay? So these are the landmarks and these are the 6 points. 3 landmarks and 6 points. Now you can see in the picture, this AA point is a fixed point which is -3 at the -3 level. Similarly, the AP point is a fixed point which is at the level of -3. Then BA point is a movable point and it can extend to the TVL. Okay. Similarly, the BP point is also a mobile point which can extend to the total vaginal length. This is a C point, which is the lowermost part of the cervix, and D point is there, which is the fornix, posterior fornix, and it is not there if the wall prolapse is there, if it is a vaginal hysterectomized patient. This is the genital hiatus, this is the perineal body, and this is the total vaginal length that is denoted by the TVL. Okay? So anything which is in minus is no prolapse. Anything, as ma'am has already showed yesterday, anything in a positive is prolapse. Like BA, this will be cystocele. C, this will be rectocele. BP is the rectocele and TVL here is 8. So anything in the positive will be prolapse, negative won't be a prolapse. Then the pelvic muscle function assessment can be done by a bimanual examination with the patient in the lithotomy position. The examiner can palpate the puborectalis, pubococcygeus muscle inside the hymen along the pelvic side walls at approximately 4 and 8 o'clock positions. Check for the basal tone, muscle tone, whether there is increased with contraction as well as strength, duration and symmetry of the contraction. A rectovaginal examination should also be performed to assess the basal and contraction muscle of the tone of the anal sphincter. These are the stages of the prolapse: 0, 1, 2, 3, and 4. And this is the picture denoting the 0 is no prolapse, 1, 2, 3, and 4th. Similarly, here stage 0, stage 1, it has come down, stage 2, stage 3, and stage 4. Thank you.
Thank you so much, Shazia ma'am. We would now proceed for a tea break, and we'll resume the session after 15 minutes.
invite me, but anyway, it's my department and I'll be more than happy. I'll be talking on non-surgical management, which we are doing most of the time. We'll be doing non-surgical. Surgery will be required only in selected group of cases. So I will be talking on little bit introduction on what non-surgical management is. Bladder diary I'll be explaining, and behavioral intervention in the form of pelvic floor training and bladder training to your case. Then, of course, bowel management, because constipation is the reason for causing incontinence, weight loss, and its importance in continence and incontinence. Estrogen deficiency with stress incontinence and its role. Other pharmacological therapy which are very limited. Then urethral devices, then ins and out of pessary, which we will be demonstrating on the model, and of course at the last conclusion of the talk. So Afsha has been talking about it is very distressing. The list was complete, but I would like to again say that these patients, they have a fear that what will I do when I get the cough and cold, because every time I cough, sneeze, the urine comes out, they stop exercising. So they become obese, and obesity is the reason for stress incontinence, and this vicious cycle goes on that their weight gain is going unchecked. Then of course avoidance of sex, fear of odor, because they are leaking urine and there is always odor emitting from their body, worry about pad cost. In our country, most of the time they are using the handmade pads, but of course disposable cost factor is there, and of course leakage from that pad, limitation of clothing. Fortunately, in our country, most of the village women, they are coming with this problem, and they are wearing a sari, 6-meter sari. And when I was a very young faculty, I still remember Dr. Lavanya was supposed to be a urogynecologist at that time from Manipal. So she was speaking about stress incontinence, and she said that stress incontinence is not a problem of our country because we wear sari and 6-meter can accommodate a lot of urine. But I don't agree with her. Anyway, the bad odor will be there. The sari, the urine may not be visible. Then, of course, toilet mapping. So those who have a urinary problem, कहीं जाना है वहाँ toilet मिलेगा या नहीं? नहीं है toilet, I will not go. So and wherever they go, they start looking for a toilet. कि कहाँ, where is the toilet where I can go in case of need? And of course, they become housebound. Yet they may take years to present for help, as we have been talking, because of embarrassment, and they accept that it is normal after producing kids. So they don't go anywhere for help. I would like to list this food because this has not been told so far. So while taking the history of increased frequency, urgency, you should also be taking what type of food that she is consuming. The food which are known to cause increased frequency are caffeine, of course, coffee, tea, we all experience after drinking how many times we go to toilet, and alcohol. Fortunately, not a problem, but these days it is becoming popular even in our female population. Carbonated drink, जो बहुत popular है, Coca-Cola or Pepsi and all those things, they cause bladder irritation. Citrus fruits are also good to taste, but they are notorious for bladder. Then spicy food, chocolate, because it contains caffeine, sugar or honey, that can also irritate bladder. And then artificial sweetener, which is very popular for especially those who are having weight reduction and they have a sweet tooth, they take sweetener, but that also irritate bladder. And of course, tomato, the food which has tomato puree and all, they cause increased frequency. So in patient with symptom desiring treatment, a discussion of treatment option should start with conservative non-surgical. We talk so much, but still the awareness is so less. Like I was today seeing my patient, and one of the case who came has stress incontinence, and as soon as I saw urine was coming out, and she was never in the life, they did a vaginal hysterectomy, but nobody ever advised her to have a pelvic floor training, which we will be talking shortly. Then many patients, they are unaware, and there are available non-surgical method also. Behavioral treatment is the gold standard for stress urinary incontinence. Of course, focus will be on changing the behavior. How that is done, I will come on to that. And of course, multi-component interventions like pelvic floor muscle training, exercise and bladder training, estrogen treatment only in those cases who are deficient in estrogen. So for SUI, the management, of course, as I said that first treatment is non-surgical, but of course it depends on type and severity of incontinence, what treatment has she got in the past, comorbidities which are associated with it, with her, then medical condition, willingness to participate in conservative surgery. Then for pelvic organ prolapse, for major type of pelvic organ prolapse, non-surgical treatment is not effective, but for the milder form and for prevention of pelvic organ prolapse, pelvic floor muscle training is very, very important. These treatments are particularly valuable for patients who are unable or unwilling to undergo surgery, or they are unfit case, that we have a non-surgical method, and the goal is to offer optimal individualized non-surgical care for both pelvic organ prolapse and SUI. Every time my finger is going there, thinking that my laptop is here. So much accustomed, sometimes, you reflexly, my finger is going there, that let me change my slide. So I'll be talking about bladder diary. So what is it is, and Shazia will make, I think she will make a bladder diary for the Department of Obstetrics and Gynecology shortly. What we did so far, we used to draw it on a paper and used to give it to the patient to maintain that bladder diary. So what all things are there in that bladder diary? Date and time, AM or PM, the exact amount of urine that she has passed on that point of time, whether she drank any water, any type of fluid, tea, water, coffee, drink, whatever she has taken, that volume has to be mentioned. Whether she leaked, like whether it was accidental leak, and urgency, how much was the urgency, and I will tell you on a scale, how do you describe on a scale, and description, like maybe what was she doing at that point of time. Maybe she was in market, she was shopping, she was somewhere and she had all these problems. At that point of time, she will note that what leakage, if it has occurred, what was she doing at that time. So bladder diary has to be maintained. Why it is considered to be so important? Because bladder diary will identify those cases with increased voiding frequency, contributing to reduce bladder capacity, and again she is going to toilet, and this capacity goes on decreasing, or benefit for those women who leak because of full bladder. They don't pass urine for hours and they are leaking. So these information we are going to get. So the bladder diary, this is the bladder diary which is from NHS, and it has mentioned everything. About urge incontinence, instruction I'll be reading later on because it is too small, you can't read it. But at urgency, how do we grade urgency? From 0 to 4. So 0 is she does not have any urgency. She has gone to toilet just in case, कि कहीं leak न कर जाए, चलो चलते हैं. So that there was no urgency, but she has gone. So that is 0. 1 is she has urgency, but she can hold her urine for 1 hour without passing. Then 2 is when she can hold it just for 30 minutes. 3 is when she is able to hold it for 15 minutes, and worst is 4 when she is not able to hold it or just for 5 minutes she has to rush to toilet. She cannot hold it for more than 5 minutes. That is 0 to 4 is for urge incontinence. And for stress incontinence, if there is no leakage of urine, it is 0. 1 is minimal leakage only with significant stress. Then 2 is moderate leakage with moderate stress. 3 is frequent leakage with moderate stress. 4 is heavy leakage with minimal stress, that means severity has increased. And constant leakage with minimal or no stress at all is 5. I could not get, like when I searched this bladder diary, which is from the textbook of Urogynecology by Mickey Karram. He has mentioned it to the scale of 0 to 4, but I could not get it. All that I got for stress incontinence, it was on the scale of 0 to 5. So I modified it. It was on because it was mentioned 0 to 5. Now for 3 full days, she is expected to maintain it. So what instruction is to be given? Start the chart with the morning void. That means as soon as she gets up in the morning, she mentions that how much urine she has passed, and then complete it for 24 hours for 3 consecutive days. So the last day will be the 4th day morning. When she will be coming to us, she will be the last sample morning void that she will be collecting will be on the 4th day, and she has to document on that diary when did she go to bed and when did she get up and how much water she consumed at night. Though those who have frequency, we tell them not to consume lot of water at bedtime, but at least 3 to 4 hours prior to going to bed they can have some water. So everything is documented there. Once she comes to us, we have to do the analysis part. So in analysis, what all we are going to do is we will have to see that how much she on day 1, 2, 3, how much urine did she produce, how much water that she consumed, water or liquid that she consumed, what was the frequency in 24 hours during the daytime and during the night time, and average urine volume per day. That analysis part has to be done by healthcare professional who can see that 3 days diary and can analyze. Then what was when she has an urge to pass urine, how much urine did she pass? Was it a very small volume or was it a big volume that she passed during the urge? So that urine output during the urge, how much did she pass, that is mentioned, and all these things are then analyzed to find out what is the reason, whether she is really having increased frequency or not. And all these 3 days are her normal days. They should not be those days when she is partying and she is having a lot of drink for some reason, like these days are not, that should not be there in the bladder diary. They are all the normal days that she spends. And now, after she has completed and we have done the analysis, we are going to do certain things to her. One is pelvic floor exercise and the other is bladder training. So I am going to talk about them one by one. Pelvic floor musculature training and exercise are Kegel exercise, which was given by Kegel way back in 1948. He realized the importance, but we neglected and we never asked our patient to have Kegel exercise. And what to talk of the patient? Every woman should do the Kegel exercise because it is such an excellent exercise that take care of so many pelvic floor disorder and urinary disorder cases. So let me tell you what is actually, I'll not read from there here. In pelvic floor exercise, what do we ask our patient to do? We ask the patient to empty the bladder and to think that she is going somewhere, she does not find a toilet and she has to hold her urine, or she is in a mehfil and she does not want to fart and she has to hold that part to prevent it. And we have been doing it involuntarily many a times, that we want to stop urine, or we want to stop that fart part. So we ask her to empty the bladder and try to hold it without taking any, and without exercising any other muscle. So remember one thing, pelvic floor muscle exercise is one exercise which is not seen by doing, when the women is doing. I am doing pelvic floor exercise. Can you make out? Can anyone sitting here? I am strongly doing it. Can anyone make out? You are also. So pelvic floor muscle exercise can be done sitting, lying, standing, driving, anywhere she can do. तो ये बहाना तो चलेगा नहीं कि हमें तो टाइम नहीं मिलता है, हम नहीं कर सकते. अरे तुम किचन में काम करती हो ना, वहीं कर लो. कहाँ, कहीं कहीं, जहाँ जहाँ तुम जा करके फील्ड में काम करती हो, उधर ही कर लो. क्या है? So, but they just have to use that correct muscle. अच्छा, मैंने अपनी एक पेशेंट को अभी थोड़े दिन पहले, अभी जब after leaving the medical college, and that patient was well off. So I was explaining to her, she has this problem and she was old also, and she never did pelvic floor exercise. So I was explaining to her, ki, think that you are traveling in a bus, the bus doesn't stop according to your wish, and you have lot of desire of passing urine and you have to hold it. Then she said, नहीं, हम बस में कभी नहीं जाते हैं, हम तो कार में जाते हैं. तो ऐसी भी बातें सुनने को मिलेगी. So you can say that कि ये तुम्हें करना है, जैसे तुम्हें टॉयलेट नहीं मिल रहा है और तुम्हें होल्ड करना है. So they will do it correct. So they just have to do the correct muscle that has to be exercised. And what, like how will you instruct her to do it? Once you have taught her, tell her that once you hold it, count. Initially, you may not be able to count to 10. Count to 3. Count to 4. Just 3-4 seconds. And then relax it totally. Again do it. Relax totally. That means the time that you spend in doing the exercise, the same time you spent in relaxing your pelvic muscle. It is very important. Doing all the time does not help, because pelvic muscle will be fatigued like any other muscle in the body. So how many? 30 to 45 per day. How many per sitting? 10 to 15 per sitting. How many seconds are they going to hold? Around 10 seconds. And then relaxation for 10 to 15 seconds. That has to be done. So its role in stress and urge incontinence is well known, but for pelvic organ prolapse, unclear, but in milder form, we do advise them. And how it is helpful. It is hypothesized that improving pelvic floor muscle function may improve structural support of the pelvic organ through muscle bulking or stiffness to improve pelvic floor symptoms. So this is how you do it. And this is from Mickey Karam, Dr. Afshan, and they have mentioned that only once per day, practice stopping or slowing the stream of urine when you void. So I have purposefully not deleted this, because at many places they have mentioned that while passing urine, you should never hold back. But they have said, that book has said that only once per day, you should do that. And of course, doing it slowly and relaxation is important. But per day, 3 to 4 quick and strong Kegel exercise should be done. Why? At least एक दिन में 3-4 बार बड़ा strong सा Kegel exercise करना है, फिर relax कर देना है. Because this action will help When they are coughing, sneezing, they can do that, and cough and sneeze, they will not leak. So this practice should also be there, doing a strong Kegel at least 3 to 4 times in a day. So this was about Kegel exercise and how does it help in stress incontinence, because we as a doctor should know the scientific basis of doing anything. Then only we are convinced and we can convince our patient for doing it. So this improves the urethral support. Patient learn to use their muscle actively to prevent urine loss during physical exertion, coughing, sneezing, lifting some weight. With practice, they develop the habit of consciously contracting the pelvic muscle to occlude the urethra before and during coughing, sneezing, or other activity which causes urine loss. They learn it. How about urge incontinence? Does it help in urge incontinence? So, urge suppression strategies are traditionally pelvic floor training muscle exercise was used almost exclusively for stress. But the voluntary pelvic muscle contraction can also inhibit detrusor action. So this will inhibit the detrusor contraction, and it is used as a component of behavioral treatment of urge urinary incontinence as well. So patient of urge incontinence are also taught, instead of rushing to toilet, what should they do? Like एकदम से urge आई, क्या उसको हमें सिखाना है? जब तुम्हें लगे कि बहुत तेज यूरिन पास करने की अर्ज है, don't rush to toilet. Sit down, relax, distract your mind. Then once and after relaxing, do Kegel exercise also. You can continue doing it, and once that urge has gone, then you can go to toilet. So cheat your bladder. Right? The bladder is cheating you, you also cheat. I am not going to go to toilet. I will relax. Then, and of course, that urge period should go on increasing every day. So, in pelvic organ prolapse, I have already said that it will improve the tone of the muscles. Then adherence and maintenance of pelvic floor exercise is important. Like whenever you ask your patient to do, tell them to continue doing it. Whenever they remember, they should do at least once, twice, thrice, they should do. And when the result comes, like एक हफ्ते के बाद मरीज आ जाएगा अगर आपने नहीं बताया है कि रिजल्ट इतनी जल्दी नहीं आएगा. At least 4 weeks, wait for 4 weeks. The result will start coming. And once the result start coming, they can go on doing it. And of course, follow-up is very important, because to track and reinforce patient progress and encourage persistence. For that, follow-up is also very important in these cases. So they can maintain. Yesterday, Afshan was talking something about electric nerve stimulation. I have never done it. I have never seen it. But what I have read from the books is pelvic floor electric stimulation. That is, that as you have said, that they take the sitting of around, for vaginal exercises, they take a sitting of 15 minutes twice a day, every day, or every other day. Once they improve or they are cured, then 2 to 3 treatments per week, they can go on to that. But as it is not available, once we don't see something, it is very hard to talk about that. Then, yeah, sure.
What I was talking about yesterday was PTNS, which was posterior tibial nerve stimulation,
Yeah.
which is our medial malleolus, just there. So we put an electrode, which is like an acupuncture, and that is attached to a machine similar what Dr. Seema showed. So it gives it continuous stimulus to posterior tibial nerve, and that is the treatment for overactive bladder. Okay. So what Dr. Seema is talking about, this is called Kegel machine, and there are various variation, and this is available for India as well. So anybody who is finding it difficult to do pelvic floor exercises, I'm sure quite a few of us in this hall are struggling to do pelvic floor exercises. So this is a good one to buy. In England, we can buy this for 60 or 70 pounds. So there is a little probe, which is just like my finger. So it is a vaginal probe. You put that probe in vagina, and this is like a battery. So you increase the strength of the stimulus. So it's electrical stimulation. You can start from mild, moderate, and then strong. So this does exactly same what we do pelvic floor exercises. Because sometimes what happens with denervation injuries like childbirth, forceps deliveries, or our nerves are not working, sometimes it's difficult to do these exercises. So this machine can do. So just 15-minute session every day. So sometimes if you can afford that, it's something good to have. So it is in the vagina. So it's a probe exactly like a finger. You put inside that probe inside your vagina. So this battery you keep in your hand or put it on the side table. So that probe remains inside for 15 minutes. And this electrically, it stimulates the vaginal muscle. So it exactly does the same thing. Exactly. It is something like. So it can be bought. And I think these things, because when India is so much advanced in technology, I'm sure it is available on Amazon because so many of
Let's
my
see on
patients.
Amazon if it is available. We can.
Original price was 300-400 pounds for the original Kegel machine, but a lot more companies are making it. Now it is 60-70 pounds. But I get very surprised that why in India nobody has done this technology stuff while India is so
maybe
advanced.
it is available. We have not seen it.
Maybe.
So I have never seen it. I have never used it for any patient. So
yeah, this is one of the common things.
Maybe
in
we'll
England.
do more research.
And another thing which is common, which is vaginal weights. Have you got a slide on this?
No.
Vaginal cones. This is that is a cheaper version without electricity.
So further. Hmm. That assess. Yeah. Yeah. What is bladder training? Actually, this is an intervention which patient has to teach the bladder actually that how frequently the bladder need to be emptied. So what the normal scenario for urgency will be that they will have a urgency. They have to sit and be stable or stop wherever they are. First, squeeze pelvic muscle quickly, at least 4 to 5 times. Wait for a few minutes. Then, if urgency persists, use distraction strategies. Once urgency lessens or stops, then wait for 5 minutes and then slowly walk to the toilet to pass urine. And this has to be done like there are 5 steps of bladder training that they maintain their bladder diary. Then each day calculate the amount of hours that you wait between each urination. Then based on that calculation, choose an interval long enough to hold between urinating and empty the bladder first thing in the morning. Of course, that we have to tell every patient, and add 15 minutes to each interval. So maybe they don't have to prolong it for a long time. They can start with the 5, 10 minutes, 15 minutes, and then they go on increasing in between. Like if they are able to lessen the urgency, put off passing urine for 5 minutes, then 15 to 20 minutes, and till they come to 3 to 4 times, 3 to 4 hours. Sorry, when they are awake, it should be around 3 to 4 hours interval that they should pass urine. And during night time, depending on their age, younger age group they don't get up, but older age group maybe two times they can get up at night for passing urine in the older age group. Though Shazia has said one time, anything more than one is nocturia, but if they are postmenopausal, they will get up more as compared to premenopausal. So what does the evidence says? How does bladder training helps? So a randomized trial has shown 57% reduction in incontinence in older women. That it reduces both urgency and stress incontinence. urgency incontinence by increasing bladder capacity and reducing its overactivity, and stress incontinence by strengthening the muscles which are responsible for holding back the urine during coughing and sneezing. And of course, additional benefit will be potential strengthening of pelvic muscle through postponing urination. When will a change occur when we are going for behavioral therapy? Do not expect anything so quick. In 3 to 4 weeks time, one should be able to see the improvement, we should always encourage the patient to continue it, and they should not be discouraged if they are not able to see the quick result of doing exercise. Then bowel management is important, as Dr. Afshan has already mentioned, that during constipation, they can have retention of urine or incomplete emptying of urine. So we should always give them dietary advice so that they do not have constipation, and laxative can be given as a last resort if they are not responding to your high fiber diet advice. Then weight reduction, again from that lecture, what I remember was overweight female has more stress incontinence, and Lavanya that time showed J. Jayalalita's photo and said that overweight is responsible for stress urinary incontinence. So it is seen that every 5 unit increase in BMI lead to 20 to 70% increase in the risk of prevalent incontinence. So weight reduction strategy is good point for curing stress urinary incontinence. About estrogen also we have talked, so I am skipping this because she yesterday mentioned the dose and everything, that what are the cases who are going to respond to estrogen therapy. For pharmacological duloxetine also she mentioned, that is though not FDA approved for use in stress urinary incontinence. So let us go on to the demonstration part. I'll just show you some devices which are there, urethral occlusive devices. Pessaries are there, especially like those cases who are not fit or pregnant. You can have pessary on those cases who are not willing for surgery, or you are going to postpone surgery for some times. Their pessary is going to help. And these are the pessaries which are available here for demonstration. So we will be demonstrating these pessaries first. Chalo, aao. These are the live demonstration. We will be demonstrating and we'll be asking them to practice it also. आइए ये टेबल इधर लाओ और ये हटा दो, इधर आ जाओ, जल्दी जल्दी आओ, जल्दी से. Because फिर वो ग्रुप्स में ना, they will, I think in group of 10 you come forward and see the demonstration, because everyone will not be able to see. We will demonstrate on the model how to apply it. इधर रख दो, यहाँ रख दो. यहाँ रख दो, ये बंद कर दो ताकि हम लोग ठीक से डेमोन्स्ट्रेट कर पाए. बंद करो. So first thing we are going to show you is different types of pessaries which are available in UK market, but maybe on Amazon I saw that some are there. So Afsha will be showing you one by one the different pessaries first. Afsha, first you demonstrate the different types. Yeah. नहीं, आप अपना आगे ले आइए, यहाँ ले आइए. रुक जाओ. क्या करना है? थोड़ा सा जगह दे दो ताकि रिकॉर्डिंग होती रहे. थोड़ा इधर आ जाओ. यहाँ भी आ सकते हो कुछ लोग. यहाँ आ जाओ. जो शॉर्ट है बस वो अलाउड है ऊपर आने. ना ये come on. Please don't block. Please don't block the recording part. Please. Don't block the recording part. Please. Okay. So my first thing I would like you to demonstrate different pessaries which you have brought from UK.
Okay, so this is the commonest. Is this not working? Okay, this is the commonest pessary which we use. Maybe I'll have the other mic. This is common ring pessary. Yeah, so everybody would have seen this one. So this comes in different sizes. This is probably size. So this is size 65. This is one of the commonest size which we use. So the good quality pessary should not be stone hard. It should be soft. Yeah. So what we do, when we are putting it in, we squeeze it like that. We don't try to put it in the same way because it will split the posterior foreshed. So usually if it is very cold weather, we just warm it up in our hands. It is not sterilized or anything, so nothing to worry about. We still should have gloves. And we usually apply with estrogen cream. So we have a tube of estrogen cream in the clinic. We apply some cream on the leading edge. We fold it like that, and then it enters the vagina this direction, not like that. So it enters the vagina this direction, which is just like that, and we are squeezing it. So when it goes in, then we rotate it to this direction.
So once it is applied here,
Yep.
what are you going to do? Ek minute.
Yeah.
Once it is applied,
Oh,
like
there
you've
is no
seen
pocket.
that it was squeezed and then applied. Once it is applied, what is to be done here? She will be demonstrating now.
Okay. So once it goes in, we have to rotate. We have to rotate. So the cervix comes in the central part of the pessary. So cervix is here. You can see cervix is in the middle, and the pessary is around the cervix. And the way we check the size, before we open the packet of the pessary, we examine the patient and we check how big is the introitus. So roughly, if the introitus is such that I can hardly put my 2 fingers in, so usually I will choose a much smaller size than this. Maybe size 55 or 58. This is 65, so this is a bit bigger. But for most of the patient, this is a good size. Okay? So once it has gone in, I've just adjusted it.
Just to add, it is not just the introitus, you will have to see the distance between the lower border of symphysis pubis and to posterior fornix. How far you have gone between the 2 fingers. One finger you put beneath the symphysis pubis and the other you try to reach to posterior fornix, and then you can assess that how big pessary the patient will require.
Exactly. And once you have put the pessary in, you part the labia and ask the patient to cough. Okay. So if it is too small, it will come out. And if it is too big, it will be hurting the patient. And then if you see that it's not coming down and it looks good size and the prolapse has gone up, you ask the patient to stand up and cough again, and then part her leg and just do this movement, so that if it is small, it will fall out in front of you. If it hasn't fallen out, this means that, okay, it is staying in. But if it is too big, she won't be able to pass urine. So what you will tell her after you have put the pessary, go out, drink some water, try to go to the toilet. If she is not able to pass urine, she needs to come back and tell you. Yeah? Because if it is too big, it will obstruct the urethra at this point.
Another thing is, once you have applied and you have seen it, you pass your finger around the pessary and see that no part of the vaginal wall is nipping into that, because if any part is pressed, that will cause lot of discomfort. So you should be able to easily pass your finger around the pessary. Another thing, like as it is said that by coughing or sneezing, the pressure applied is very transitory, minimal and transitory. So you can ask her to do Valsalva also. Because once she will do a Valsalva maneuver and she is able to retain the pessary is not going anywhere. And if she does a Valsalva maneuver and pessary comes out, that means pessary will be out once she go back home. So tell her to walk, stay in your hospital for some time, and if everything is fine, she can go back home. Can we have the site of other pessary, and then we will have questions which are based on, because for that everyone can sit and then
So,
You
so this
show
is a
other.
shelf pastry. You might have seen this. This is size 12. So the commonest size which we use is 9, 10, 11, 12. But if somebody has procedentia, very, very big prolapse, the largest size available is size 20, which is that big. Because sometimes the prolapse has swollen so much because of edema, and the genital hiatus is more than 6 centimeters, and this is not going to stay in. So the smallest is size 6 and largest is size 20, but this is the commonest size. So because this is very, very hard, it gives very good support. But whenever we're using this, we use lots of estrogen cream. So I'll cover this whole surface with estrogen cream. And then this pessary goes in like that. So again, always this direction. So, and then there is a curve there. So I I introduce it like that. And I slide it up like that. And then I keep sliding. And then at this point, I tell patient that it's going to be stretched. And with this finger, I just move it like that. So this curve, urethra is not pressed, there is a curve. And I tell patient, this knob is there for you to push it up when you are about to open your bowel, because when you strain, this will come down. And with your one of your left hand, you can put this finger there, and then you push the poo out. And whenever it comes down, when she has done a lot of heavy lifting or household work, you can tell her, wash your hands and gently push it up, it doesn't harm you. So this knob is for control of the patient as well as to get it out. Getting it out is tricky because what happens with the vacuum, this gets stuck there. So sometimes it can be tricky. So in order to get it out, because this you can easily hook out and take it out, and inside the body it is quite soft. And because this is hard, it doesn't get softer. So first of all, you need to release the vacuum. Unless you release vacuum, no matter what you do, it will not come out. So your finger goes on the back. There's a little hollow. You release the vacuum, you put your finger across, and then gently you try to dislodge one there, and also it comes out sideways. So this is under urethra, so urethra doesn't get disturbed, and this is posterior. Okay.
Just one more thing, like as you mentioned that in procedentia or in a prolapse, there can be lot of edema. There can be decubitus ulcer also. So treat that first. And what we do with vaginal packing, with antibiotic, treat that first before you decide to apply the pessary.
Exactly.
With any like tissue edema or decubitus ulcer, don't apply pessary. Once you treat, the patient is fully treated for that, then
Okay, so the next one is Gellhorn pastry. So Gellhorn pastry is very soft. It is like a mushroom. So you tell patient, oh, this is like a hanger, this is like a ring, and this you tell is like a mushroom. So it comes in two types. One is a short stem Gellhorn and one is a long stem Gellhorn. Some people who are very, very tall, their vaginas are also very long. So this long Gellhorn is easier, so that it's easier to remove. But sometimes the people who have short vagina, if we use long stem, that this knob will be visible. So usually we use short stem in like average people like us who are not very tall. Again, this is extremely good quality and it can be reused in the same patient, but never for another patient. So it can stay in for 6 months. All pastries can stay in for 6 months. We'll talk about that. Okay, so first of all, we'll put lots of estrogen cream all over this surface. And then what we do, we squeeze it like that. And again, it goes in like that. So it is soft. It goes like that. You part the labia. It goes in, goes in like that. You keep squeezing. And then, because it's quite big for this patient, so this knob, we can adjust the position with this knob. And you tell the patient this knob is for her to control. If it comes down, she can push it back up. And in order to release, most important is release the vacuum. Remember that? So you just go on the back. Once the vacuum is released, and then you get it out sideways. So this is short stem Gellhorn pastry. Okay, so we move on to the cube pastry. Cube pastry is when vagina is very, very roomy, yeah, and small pastry will not stay in, which is the ring pastry. So this pastry has a lot of bulk. So the people who are obese or the vagina is very, very roomy and it has air in it. So, and then patient can also manage it herself because it is quite big. So it's easier for patient to put her finger there and get it out. So this can be managed by patient. So this is called donut pastry. So it goes in like that. But first time, because obviously this is a small vagina for this pastry, but this is for people who are quite big vagina, floppy vagina. So go sideways and then you turn it and then it stays there. So this can be managed by patient. Another one which can be managed by patient is cube pessary. This is the typical one which is used a lot in sexually active patients. Because when pessaries are in, with this one, sexual intercourse is compatible, but with all this, it's not possible. For younger people who are sexually active, this is the one pessary of choice. And this is most commonly used in America, and this is always for self-management. So this has a loop like that. So patient always uses it herself who are sexually active. So what they do when they don't need to have sexual intercourse, they just squeeze it in any direction, they put it in, and then when they would like to have sexual intercourse, they can just pull it out themselves. So it is very, very easy because easier to manage. So and the thing is they don't have to squeeze in any particular direction, any side they can squeeze. And any direction they can put, they can't go wrong. All they need to do, the loop should be inferior. So any direction, because it becomes very soft in warm temperature, they can just put it in like that. And any wall prolapse, anterior posterior side, because it is cube, it will give them support, and this loop is there. As soon as they want to have sexual intercourse, they just pull it out gently like that. So this is the one which is easiest for younger patients. Of course, a little bit smaller prolapses. Yeah. One is left. This is similar to Gellhorn, but without the knob. Yeah, I'll tell you. So this is called Schartz pessary. The name is not Gellhorn. This is called Schartz. And the size is 76 millimeter. Again, because some patients find it very annoying, this stem, especially if they have short vagina. When total vaginal length is less than 6 centimeters, then this is very annoying because this is present there when they sit down. In that case, we use Schartz, which is without the knob. So it's exactly same job. It just goes like that, and then we turn it, and then exactly same, and then it comes out similarly with estrogen cream. Yeah? And this is similar to ring pessary. The benefit are two. It has a membrane. Because if somebody has cervix popping out, if somebody has elongated cervix, elongated means more than 4 or 5 centimeters. If we just use ring pessary and cervix is there, cervix can still pop out. So what this will do, this will keep the cervix away, but little holes, the little secretions from the cervix or periods, it can still come out. Okay. Another benefit of this particular, this is one of the most expensive one, Cooper Surgical, it makes it. So there are two areas which are flexion points. So here and here there are flexion points. So you just flex it like that. This is a very small size, and then it goes in like that. And then once it goes in, you adjust it like that. Yeah, again getting it out, you just take it out like that because it's very, very soft. So all these are support pessaries. Now we are talking about a device which is called Devine device for stress incontinence. It is for younger people. So what happens in stress incontinence? Our skeletal muscles around the urethra, they get weak. Yeah. So this device, what it does, it stretches the anterior vaginal wall. So the muscles which are getting saggy, if you think about it, this is our pelvic sling. So it has become like that. So the urethra is here. So muscles around it are unsupported. So what this device does, you will see. So this is the plunger. So this patient can use herself if she's going for running. She can push this inside her vagina herself like that. And then this can stay out. So what it does, this is vagina. So it will stretch the vagina like that, anterior vaginal wall. So it will support on both sides of urethra. It does exactly the same what Birch-Colpo suspension does. It lifts the urethra from the side. And when the patient needs to bring it out, she can pull it out, wash it and put it again inside that, and it can be used before running or anything. So it is something which they can do whenever they want to. Sports activity, going to gym, or they can control it whenever they want. So this is Devine device. There is another device which is exactly like this one. No membrane, but there is a signet device. So there is a ring exactly like a ring. There is a knob. So it can be put like that this knob remains just under urethra. So that is also another device which is called incontinence dish pessary. So there is a name for it, incontinence dish pessary. So there is a knob like that over here. I couldn't bring that. It was not available that day in my clinic. So the only one left is this one. So it looks like a shelf pessary, but it is not a shelf one. It is called poppy pessary. So you see, it is exactly same what it is. Exactly same. This is number 12. This is number 12. Exactly same size, beautiful. The only difference is it is soft. Yeah? Although there is benefit of being hard, because hard gives better support, but sometimes it can cause friction and problem. We'll talk about troubleshooting. And sometimes getting it out and putting it in is very painful with shelf pessary. So this has come in the practice. So it is soft. So we can just slide it, it doesn't hurt and it's easier to get out. And sometimes we can hold it with a tenaculum when we are getting it out. So that is a benefit. So this is called POPY, P-O-P-Y, this is shell. So that's all the names of the pastry, all possible
After the
pastries.
demonstration, I will request all of you to take the seat and I am going to ask a bunch of questions from Afshan and she will be answering each. So I think I will also come down. Yahi pe abhi chhod do. These are all property of obstetrics and gynae department and they will go to Professor Zahra Mohsen. Well, after this has become a property of you, the Obs and Gynae department. So Afsha, I think we can sit here and we can address the questions from here. Okay? So after we have seen all the types of pessaries which you must have seen for the first time. Even I also saw many pessary for the first time. Afsha, what are the indications of applying pessary in modern day urogynecology?
Okay, so there are a lot of indications of pessary, so I think this is not very helpful. Okay, so whenever somebody is there with the, of course you can come and see.
We will demonstrate. Listen, even it and we will demonstrate. Even if others have gone, we will demonstrate. Yeah.
Of course.
Yeah. Of course we will demonstrate.
So we should always offer in urogynecology patient for prolapse and incontinence all the available options. We should never assume, oh, this is older woman, she can have only pessary. This is younger, she should have surgery. Because it is not defensible in court of law. Because no of the surgical treatment or invasive treatments, number one, they are 100% successful. And number two, they are not without complication. So in the UK practice, you cannot offer surgery unless you have explored or offered patient conservative management. That's why the first management option in all incontinence and prolapse is do nothing. Because you can just explain to patient prolapse and incontinence are unavoidable things. These happens, it's not life and death. So if you decide not to do anything, that is an equally good option. And you must document in your notes the first option is doing nothing, which is obviously not acceptable. Then you move on to conservative measures. And in conservative measures is a physiotherapy. If patient declines that, or if she tells you she has already done it and no benefit, then you move to pessary. Yeah? So then you talk about pessaries as a foreign body. And you tell them it is not part of your body. And once you are putting the pessary, it must come out. And it needs to be taken out every 6 months. We'll talk about it. So the indication of the pessary could be control of urinary symptoms, mostly prolapse symptoms. But once we have offered them pelvic floor physiotherapy or doing nothing, then we can talk about pessaries. So it can be done in any age group, but usually we have to keep in mind if they are sexually active or not and how important is that aspect of life to them. If they are not sexually active, then it's a good management option. If they are sexually active, then cube pessary or self-managed pessaries are an option.
Who are the cases where you will never offer them a pessary?
Yeah, patient with severe vulvovaginal atrophy, unless the atrophy is dealt with, or person with local abnormalities like lichen sclerosis or other condition, when introitus is so small that it will be excruciatingly painful to insert or remove the pessary.
All right. So how do you choose the pessary? Suppose a patient has chosen that she wants a conservative management and she wants a pessary, or maybe as a temporary method she wants it. So how do you choose which pessary is going to be fit for her?
So it will depend on type of prolapse. If it is central prolapse, which is just the uterus and cervix, then ring pessary is a good option because it will surround. Gellhorn pessary is a good option. Schartz pessary is a good option. And the ring pessary with the membrane is a good option. But if it is vault prolapse, then the ring pessary is not going to do anything, because for vault prolapse you need something more like a shape of the vault, which is shape of the shelf. Then shelf pessary and poppy pessary is the ones you are going to choose.
If she has associated distress incontinence as well.
Yeah. So again, shelf pessary supports urethra because there is a gentle curve. So that can help. But sometimes shelf pessary will make stress incontinence worse. because vault is kinking the urethra. And when you correct that kink, stress incontinence get worse. So whenever you put a pessary, you can tell patient, it may make you incontinent. This is something you must tell them, unless we are using incontinence dish pessary, which has a knob which is under the urethra, which can control.
Okay, so with your years of experience in UK and you have used pessary as well, what all complications did you come across and how did you manage those complications?
The first one is failure of the beneficial effect. The pessary has come out straight away. So expulsion of the pessary, which can happen in 2-3 days time or straight away. So that is a drawback, that you have put a pessary, it has come out. The reason is maybe it is not the right shape of the pessary which you have chosen, or maybe not the right size of the pessary. Yeah? Or maybe the extent of the prolapse is so big now, like stage 4 prolapse, it is difficult to control unless you are using shelf 20 size pessary. Yeah? So maybe it is type of the prolapse or the type of the pessary that it has failed. Other complication of chronic pessary use, if it is neglected pessary, if the patient has forgotten and 6 months have passed, it can cause ulceration and it can cause severe discharge and bleeding. And if that doesn't happen, it can cause fistula. So if you use like 300 or 400 pessaries, maybe 1 or 2 patients can use, can develop fistula if it is neglected over 1 year of time.
Yeah, we have seen in 1 or 2 cases where granulation tissue was grown over pessary.
Yeah.
And it was a hard pessary, of course, and must have led to a lot of erosion around and then. So how do you care for a pessary once it is, how many visits a patient will require to get a correct size of pessary?
If you are doing this pessary regularly and patient is lucky, maybe the first visit will be enough, because you will know that you will make your judgment that this is the right size. But we usually have a specialist pessary nurse. Her job is just to do pessary clinics. So if I've seen a patient and I put a pessary, I give her a card that if you have any troubleshooting, because I may not be available, so that patient will contact that specialist nurse, and her job is, she has a full trolley of pessaries and she's trained, we have trained her. So if I'm not there, then she can put one size bigger. So usually when I put a pessary, I write a plan in the notes. I put shelf 12 or poppy 12. If it comes out, we can try shelf 14. And the nurse will follow that message when patient is there. So it's a service we need to develop with the pessary. It's not the one-off.
One person cannot do everything. So what advice do you give them, that, like how to care for that pessary, how frequently to wash it, till what time that can be there in the vagina without taking out and washing? So tell us the details.
Yeah, 6 months. Every 6 months pessary needs to be changed. But I have done some research on this particular subject. So there is an article in International Urogynaecology Journal, and I'm the first author. If you search how often shelf and Gellhorn pessaries should be changed, that is the title of my article, and I'm the first author, and Professor Robert Freeman is the second author. It was published in 2014 in Ayuga Journal. So that's a good article to have in your clinics, to put it on somewhere. So there is that describes that if you don't change pessaries, what happens, what is the incidence of fistula formation. And anyone who is using a pessary, they must use vaginal estrogen cream if there is no contraindication like breast cancer. So this cream should be used every night for 4 weeks and then twice a week for 4 months. And then they come after 6 months. You check them and you make sure there is not enough atrophy. And if there is, you tell them to use again the cream for next 4 months.
So, for applying a pessary, should they use vaginal, if they have a vaginal atrophy, should they use the cream before applying the pessary, or at the time of application of pessary, you can ask them to apply vaginal?
Yeah, because this will be your only chance to see the patient. So you will give her prescription of estrogen cream in the same sitting and tell her from today for next 4 weeks you will apply cream every single day. It's really important.
Any serious complication you saw with pessary?
Yeah, so pessary impaction leading to fistula. But if pessary is causing a lot of bleeding, then sometimes it can be missed that if it is actually postmenopausal bleeding because of endometrial cancer or cervical cancer, because then people say, oh, it's pessary bleeding, but actually it is cervical cancer which is hidden underneath the pessary. And because of prolapse, sometimes cervix is not visible, sometimes it is endometrial cancer, or sometimes the bleeding is coming from tubes because fallopian tube cancers. So this is could be a red herring that because of pessary you are assuming it is friction bleeding. So they need to be investigated. The usual course of action will be to remove the pessary, ask for transvaginal scan, check endometrial thickness, and when you remove the pessary, inspect the cervix very well.
Okay. Any other question?
Sorry? Yeah. Yeah, so these pessaries get discolored with menstruation, but the menstruation does not harm the pessary. But for younger patients, these pessaries are not useful under 50. So because they are sexually active mostly. So if they are sexually active, only Q pessary will be applicable. So they can remove the Q pessary during periods because there is a ring underneath, they can pull it out. Because during period, they will find it difficult, the blood is impacting here and there. So, but other pessaries are usually managed by professionals, but younger people, my advice will be just to use Cube pessary or the incontinence device, which they can manage themselves with a loop.
So once the patient, you advise a pessary, once she goes home, she comes back to you after 6 months?
Yeah, 6 months. And you just remove the pessary, inspect the pessary. You can wash the pessary. If there are any cracks, then you don't wash, you put it in the bin. But these are extremely good quality pessary, and these are all reusable. So you can use them at least 3 visits, which means 1.5 years.
So do you also advise you to pull them?
No, no.
She wears the pessary for
6 months. Yeah, yeah. Because they stay in the, they are all fixed in the upper vagina. So lower half of the vagina is functional, but with sexual intercourse, you must warn them that only with the ring type pessary they can have it. Anything with the knob, it can hurt them because maybe they have not warned their partners or something. No, every 6 months it needs changing. It only needs estrogen if it is good quality pessary.
So I just want to say one thing. Prior to administering the pessary, we have to get a screening, cervical screening, whether we should exercise more and more.
Yeah.
They are in place, already they are in place.
Yeah, yeah, because sometimes it can be hidden, cervix can be hidden. Yeah. And for transvaginal scan, they need to get the pessary out.
Any other question? If there are no questions, we can go on to the next case presentation and we can have the demonstration.
And it's already 6. Oh, maybe we can do it tomorrow then. So what we can do,
Those who were left, they can come.
they can
for
come
the
now.
demonstration.
And all of us, you can also come and have a
Actually, most of the clinical part was covered today very nicely by Dr. Shazia and Dr. Afshan. So we will have tutorial demonstration. Some place so that the recording goes on. ये बंद कर दीजिए, recording चल रही है. थोड़ा सा अफशान आगे आ जाओ. Recording भी कर रहे हैं. ये वो है. आप अब कर.
This is Cube pessary. Okay, so this is Cube pessary. And the benefit of this pessary, this can be self-administered by patient whenever required. So it's an ideal situation for a younger patient who is sexually active. So before sexual intercourse, he can pull it out with the loop. So what do you do? The reason is it is very, very soft and pliable. So she can pinch it in any direction without harming the contours.
That means if the patient is sexually active, she should not use
Any other. Unless this one, because this is compatible with sexual intercourse, because it goes right up. So this one, she will just squeeze in any direction, it will not harm. Whatever way she can do. Only thing is the loop is underneath in the lower part. Like that. And then this is there. So when she wants to get it out, she can get it out easily without harming it. And it is very good quality. This is donor pastry. Patient, it is also self-administered for people with very large genital hiatus and very floppy vagina and obese patients. So it will go in and it will stay in, it will provide a lot of support. Any prolapse in vagina is very long and floppy. Yeah. This is poppy. It is exactly like shelf, but it is soft. So poppy and this is shelf. So it goes like that, always on the side. You keep going, you go like that, and then you adjust the knob and tell patient this knob is for her to manage. If it comes out or she's about to open her bowel, she can put her finger here. Otherwise, she will worry that it will come down because with large prolapses, it can come out up till now, up till quite out. So she can push it up. No. In order to remove, it will never come out unless you release the vacuum. Because it creates vacuum underneath. No matter how much you push, it will not come out. Never ever. This one, these two, you have to release the vacuum. You put one finger in the back and you just put your finger, slide all across it. Vacuum is released and then you tilt with the one side like that and always one knob comes out like that. Always. You never try to put, because what will happen, you will have a tear of posterior portion. Yeah? Yeah, yeah, exactly. No, no. It is for people who have very roomy vagina, very, very large vagina, so it doesn't. And it produces, just gives them some support to lift everything up. But I don't use this very much because this is usually for patient, mostly in America. This is too hard, but this is the best support. If I have to choose one pessary for clinical practice, I'll use this. For anything, for procedentia, for wall prolapse, people who are not sexually active, my choice of pessary is this. Exactly, and very, very good support because this is soft and with body temperature it becomes softer, so it can slip out. But everybody knows in my department, this is my favorite pastry. So I've got all possible sizes and this is the one which will never fall out. Will give good support and equally good quality. But estrogen cream is a must with this. Yeah. And sometimes what you can do, because estrogen is must with that, so there is a little tiny ring, like a ring pastry, but very thin ring, which is called E-string. So there is estrogen in a ring. So you put that first, and then you put this or any other pastry on the top. So that E-string will keep providing estrogen for 6 months, and it is sitting on the top of it. So that continuous supply of estrogen from that little ring, it will sort it out. So that is the best management. So she has 2 rings. One is very, very thin. It is as thin as this part of this pessary, like that. It is only small. So you put that first, and on the top you put this, and she is sorted for 6 months. Yeah? Yeah, yeah. Yeah, this is a small size, so it comes in bigger size. So it is not for support. It is only for stress incontinence. Because the purpose is because this part goes up, and this is where the leak is. Because the patient will do it herself. So if you think about it, so this will be here, and this part is where urethra is. So this will keep like a plug just under the urethra, like that. So this part is closing the urethra, and this is holding it up. So this part is only to hold it up with vacuum, and this is what's giving strength. And she can pull it out like that. It's very, very easy. By us, these two are, this is for stress incontinence or any incontinence. Yeah. Usually it's a bigger size, not this. This is a smaller size. This is self-centering with a magnet. Yeah.
alternate surgery. If somebody is not fit for surgery or somebody couldn't write surgery, then we use this. And it is one of the options because not every surgery is successful. Sometimes the child has complication or we have done surgery with chest pain. Then efficacy of this, I would say 80-90% will be happy if we have the right choice. But actually first few visits in treatments wise, we try various one and then we come to a point where side effect friction healing, which can be continued to 4 months or pain or they can't accept.
Attention, everyone. Thank you so much. I would now request you to please be seated. I now take this opportunity to thank Professor Seema Hakim ma'am for bringing life to the session with her demonstration and such illustrative lectures. And I would also take this opportunity to thank Dr. Afshan ma'am for taking time out for us and for explaining and clearing all our doubts. Thank you so much.